In this video, we're going to talk about the different types of parenterals. We can formulate injections as aqueous solutions, suspensions, oily injections, emulsions, colloidal solutions, mixed solvent systems, concentrated solutions, and powder for injections. And finally, we have implants, but these are not injections. They are solid preparations that we insert under the skin, as we'll see later on. Let's begin with aqueous solutions. They are suitable for all routes of administration, provided that the active constituent is soluble. They are the simplest and most convenient preparations for injections because they are isotonic and they have a pH of 7.4, meaning they mimic the pH of physiological fluid. Antioxidants are only added if the active constituent is susceptible to oxidation in order for us to stabilize the preparation, such as with sodium sulfite. Remember from the previous video that we can never ever add antioxidants into injection formulations as they have irritant and toxic properties. We can package the aqueous solutions in two types of containers, the first one being single-dose containers. If aqueous solutions are packaged into single-dose containers, then they are used only once as a single dose to be injected, and then the container is discarded, and as such, they do not contain antimicrobial preservatives. On the other hand, multiple-dose containers or multi-dose containers are when the drug are withdrawn multiple times over several doses, and as such, they must contain antimicrobial preservatives to reduce contamination. Multi-dose containers are usually glass vials with rubber stoppers, as we can see from this diagram. And every time we withdraw the drug, microbes in the air have a chance to contaminate the preparation, and therefore we need to add antimicrobial preservatives to reduce the risk of contamination. As such, the use of multi-dose injections is considered poor pharmaceutical practice as the preservatives themselves have toxic effects and because of the potential for cumulative contamination. That's why when we prepare injections to be packaged nowadays, we aim to package them into single-dose containers with no preservatives added. Let's see a practical example of this. Here we have a lidocaine hydrochloride injection label. I want us to notice here that the solution is packaged into a single-dose vial with no preservatives added, as we just said. An example of aqueous solutions is local anesthetics for intraspinal injections. When we come to prepare aqueous solutions for intraspinal injections, we can control the density of the solution in order to localize the site of drug action in the spine. We adjust the density relative to that of cerebrospinal fluid. Why? Because we inject the local anesthetic drugs into the cerebrospinal fluid, so it makes sense to measure relative to it. As such, we can classify intraspinal aqueous solutions into three types: hypobaric, isobaric, and hyperbaric aqueous solutions. From its name, hypobaric solutions are less dense than cerebrospinal fluid, and hence, upon injecting the local anesthetic, the solution would spread upwards. Likewise, hyperbaric solutions are more dense than cerebrospinal fluid, and hence spread downwards. Isobaric solutions have the same density as cerebrospinal fluid, so they remain localized at the site of injection. Okay, so how do we actually adjust the densities of the solution? Well, we start with our base, which is the isobaric solution. To the isobaric solution, we add dextrose if we want to prepare a hyperbaric solution, or sterile distilled water if we want to prepare a hypobaric solution. Next are suspensions. There are two types of suspensions depending on the vehicle we use. We have aqueous suspensions and oily suspensions. Let's start with aqueous suspensions. We use aqueous suspensions to deliver insoluble drug particles or active constituents that are adsorbed onto an insoluble matrix to promote modified release of the active constituent. Examples include insulin zinc suspension and procaine penicillin injection, which are included in the British Pharmacopoeia. Oily suspensions are less commonly used, but if they are used for their depot mechanism, and as such they are formulated as intramuscular injections. An example of an oily suspension is stearal penicillin G procaine with aluminium stearate suspension as indicated by the US Pharmacopoeia, and this is actually used by vets to inject into animals. Oily injections. They are intramuscular injections, and they are basically lipophilic drugs in oil. And we can use different types of oils. We can use simple oils such as ethyl oleate or compound oils such as arachis oil or sesame oil. Oily injections are mostly used for injecting hormones such as progesterone, as we can see from this diagram. And here we have the label of the progesterone injection. Again, I've highlighted the parts relevant to us. Oily injections are used as intramuscular injections, and the active constituent, which is progesterone, is placed in an oily vehicle, in this case, the sesame oil. Emulsions. We can also formulate lipophilic drugs as oil in water emulsions, where the drug is either dissolved in an oily solution and then emulsified, or the drug constitutes the oily phase of the emulsion. Emulsions are widely used to formulate total parenteral nutrition intravenous infusions, such as intralipid, which we inject as a nutritive fluid for patients who are comatose. These emulsions usually contain up to 15% of emulsified vegetable oil. If we take a look at the components of intralipid, we can see that the majority of the emulsion is composed of the vegetable oil, in this case, soybean oil. The emulsifiers are phospholipids, which are added to keep the emulsion stable, and the external phase is the water for injection. Other than formulating emulsions as total parenteral nutrition infusions, we don't really formulate injections as emulsions because it is difficult to maintain the droplet size of the oil to less than a micrometer, and therefore it's difficult to ensure the physical stability of the emulsion. Colloidal solutions. They are made of two phases, the continuous phase and the dispersed phase, and the dispersed phase must have a particle size between 0.5 micrometers and 1 nanometer. These preparations are sterilized using an autoclave, and examples include the iron dextran injection, as we can see in this diagram, and also iron sorbitol injection. Mixed solvent systems. These are preparations containing two or more solvents, and we use them when the aim is to prepare a preparation with an insoluble drug, which, when injected intravenously, is completely miscible with serum. Hence, the solvents here enhance the solubility of the insoluble active constituent in the preparation. Examples of co-solvents that we can use include ethanol, glycerol, and propylene glycol. And here is another label of the digoxin injection, and I want us to notice that propylene glycol and anhydrous ethanol are used as the co-solvents to enhance the solubility of digoxin. Some formulations contain several co-solvents to avoid the use of a single co-solvent in toxic quantities, and examples are the digoxin injection and the ergotamine injection. Concentrated solutions. They are sterile solutions intended for injection or infusion only after dilution in a larger volume of fluid. So they are essentially solutions concentrated in the active constituent we want to deliver and in large volumes, which we will later dilute and use smaller volumes of if we are formulating solutions for injections. I have a question for you. Why do we prepare a large volume of concentrate and not a large volume of diluted solution? Diluting initially large volumes of concentrates is more economically favorable in manufacture, as it allows us to carefully control and reach the desired level of dilution. On the other hand, working with an initially dilute solution is less efficient, as we may want it to be less dilute, for example, which would just be a waste of our resources. When we dilute them, we use an aqueous liquid to do so, like saline, which is 0.9% weight per volume sodium chloride, or water. And of course, we dilute before administration. An example of concentrated solutions is potassium chloride, and it is used in its diluted form to treat potassium deficiency. In this case, it is important that the potassium chloride is administered into the patient in its diluted form and not its concentrated form, because fatal cardiac arrhythmia and cardiac arrest occur when the potassium chloride is administered in its undiluted form. And even on the label, it's written in capital letters and in red that it must be diluted before use. Powders for injections. They are dry, solid, sterile parenteral dosage forms prepared for drugs which are unstable in aqueous environments, meaning that they are degraded by hydrolysis. In basic words, they are simply powders in a vial to which a suitable solvent is added, and usually the solvent that we use is water for injection. What is the purpose of powder for injections? They allow us to formulate drugs that are normally unstable in aqueous environments so that we can benefit from their therapeutic effects and administer them as injections. Before we can use them as injections, though, we need to reconstitute or dissolve them in a suitable solvent. The powders themselves can be dry-filled powders in vials or lyophilized powders, meaning that they are freeze-dried. And an example of powder for injections is aminoglycoside antibiotics. Lyophilized powders are prepared in a process called lyophilization. But what even is lyophilization, and how does it work? Lyophilization means freeze-drying. More specifically, we are removing any water content from the powders, and the aim of doing this is to stabilize and elongate the shelf life of our injection, as well as to reduce the risk of contamination by microorganisms. Basically, the drug to be lyophilized is dissolved in a suitable solvent to form a solution. After we form the solution, it is then sterilized by filtration to remove any particulate matter and is placed in a vial. It is then taken into a freeze dryer, as we can see from this diagram, and freeze-dried by the low temperature inside so that the water turns into ice and so that it forms crystals. It is also exposed to very low pressures by application of a vacuum, and the solution is gently warmed so that eventually the water content of the drug solution changes directly into vapor and is removed by sublimation, leaving the sterile drug in the vial, which is at the end closed and sealed to maintain sterility. The advantages of lyophilization is that no heat is involved as opposed to preparing dry-filled powders. Lyophilized powders are better than dry-filled powders because they are more porous, so that when we come to reconstitute the powder to formulate them as injections, they dissolve more easily. And finally, they give an elegant, sterile, and particle-free preparation. However, the disadvantages is that they are costly, and there is this constant need to maintain sterility following sterile filtration, which we did at the very beginning. Finally, implants. They are sterile, solid preparations implanted below the skin, as we can see in this diagram here. It provides slow and controlled drug delivery over a prolonged period of time, such as over months, and they are used for drugs which cannot be taken orally, for hormone replacement therapy, and as contraceptives. Examples include implants used for bone infections, testosterone implants, and progesterone implants. And with that, we finished the types of parenteral preparations.